Hello, everybody, and welcome to Doctors Chillin, your premier podcast on the art and science of medicine and interesting topics in healthcare. We're coming to you from Nashville, Tennessee, one of the biggest and most important healthcare cities in the United States. The Hospital Corporation of America, that global behemoth of a healthcare company with its 190 hospitals and approximately 2,400 ambulatory sites of care in 20 states and the United Kingdom, and nearly $120 billion in market capitalization, that HCA. And today we're coming to you from HCA's flagship hospital, Tristar Centennial Medical Center, a 741-bed comprehensive medical and surgical facility and Nashville's only 5-star rated hospital according to CMS, that's Centers for Medicare and Medicaid Services. Right now, it's the end of the day for some of us, and we are just chilling. No white coat, no badges. Badges? We don't need no stinking badges. No ties. The hair is down, and we thank you for chilling with us. We are here to relax and learn. What a great combination. And we've got a great show today. I'm so excited about it. But first, are you looking for a primary care doctor? Have you tried to get a primary care doctor and been told that it would take several months to see one? Well, look no further than the Centennial Internal Medicine Continuity Clinic. You will see a resident, a doctor in their last few years of training, who is overseen by some of Centennial's finest faculty physicians. Call 615-340-2275 today to be seen in a matter of weeks. That's 615-340-2275 for the Centennial Internal Medicine Continuity Clinic. The Centennial Internal Medicine Continuity Clinic, now accepting new patients. Call 615-340-2275 today and tell them Doctors Chillin sent you. I am so thrilled to introduce our very first guest to Doctors Chillin, Dr. Vivek Subbiah. Dr. Subbiah is the Chief of Early Phase Drug Development for Cancer Treatment at the Sarah Cannon Research Institute here in Nashville. He has been the principal investigator in over 150 Phase 1 or Phase 2 trials, author on over 450 peer-reviewed publications, addressed the United Nations twice, and is the host of the JAMA Oncology podcast. Welcome to Doctors Chillin, Vivek.
Thank you so much for having me, Phil. Thank you so much. It's a pleasure and honor and fun as well.
Thank you so much for being our first guest. Now, you are a podcast host. I want to plug your podcast.
Thank you.
Everybody, Dr. Subbiah hosts the JAMA Oncology podcast with new episodes that come out once a month. JAMA is big time. JAMA stands for the Journal of the American Medical Association, one of the premier medical journals in the United States and the world. Dr. Subbiah interviews authors at the cutting edge of cancer research with podcast titles I can barely understand, like Olverembatinib after failure of tyrosine kinase inhibitors, including ponatinib and asciminib. Did I say that right?
You got it right. You
wow,
got it right the first
all
time.
Right.
Wow.
Very
That's
heady
amazing.
stuff.
Yeah.
So from host to guest, which is harder, to be the podcast host or the podcast guest?
I think the easiest part and the fun part is to be a podcast host. I think.
Thank you. Yes, it is.
And again, it's amazing to be in oncology and oncology research because so much cutting edge research is going on.
Yes.
And I'm privileged and honored to interview amazing faculty from all over the country, all over the world. And the first are senior authors of amazing publications that have made it to JAMA.
Yes.
And they are phenomenal publications. I get to learn a lot as a host. The easiest part is to ask questions. So if you want to listen to those JAMA Oncology podcasts, I can probably put a shameless plug here.
Absolutely.
You need to go to jamanetworkaudio.com or just search for JAMA Oncology Podcast wherever you get your podcasts.
Wherever you get your podcasts, links below. There we go. So let's get into it. Vivek, chart your journey of how you got to be where you are, starting from when you first desired to be a physician and the people and events that are especially memorable and were most instrumental to getting you to your present station in your medical career as a leader in cancer research.
Oh, thank you so much for that question. Again, I grew up in India, in southern part of India, in a city called Chennai. When I grew up, it used to be called Madras. Madras, Madras. Now they changed the name to Chennai. So Chennai is an interesting city because it's a beach town, beach city.
Nice.
And it has the world's second longest beach. And I remember my grandpa and I used to walk almost every day in the beach. And it's a 6 to 7 mile long beach.
Yeah.
And the beach had statues of famous people.
Wow.
And my grandpa, and I was 3rd grade, 4th grade, 6th or 7th grade, he used to talk about those famous people and why they are famous, what did they contribute to humanity. And that started my thought process during 7th or 8th grade. I'm like, no, I need to help humans. I need to help humans. I cannot think about myself in business or something else. I need to help humans. An easy way to do it is being a doctor, serving people, serving patients, right? So that was the inspiration for me to get into medical school. So after medical school, I moved to the US. In fact, I was a visiting scholar in the emergency department at Stanford. So it was amazing time at Stanford. And then I did my residency in Cleveland, Ohio.
Cleveland rocks. Mistake
Cleveland.
by the lake.
Again, beyond the mistake by the lake, when I was there, the Cleveland Cavaliers had this person you may know called LeBron James.
Yes! The chalk.
Yes. I used to watch all those games.
Yes.
And I had friends and colleagues in Cleveland Clinic who used to get me tickets all the time.
Wow.
Yeah. So again, Cleveland, I did a residency. I don't know if people would know this. It's a med-peds residency. It's called a combined internal medicine pediatric residency. So people do either an internal medicine residency or a pediatric residency. This is combination. 6 years squeezed into 4 years. So it was a rough and tough residency that laid the foundation. So during that time, I met with mentors who channeled my thought towards oncology.
Okay.
Again, I was initially thinking about ID, HIV research, but oncology had everything in it.
Yes.
And so I moved to Houston, MD Anderson Cancer Center.
My hometown. Yes.
Houston,
yes.
Wow,
Loved it.
that's awesome.
H-Town.
Again, Houston shaped me.
Yes.
Again, so I moved to MD Anderson Cancer Center, which is one of the largest cancer centers in the world. And I came there for my fellowship training. And to their eternal credit, they designed a special fellowship for me.
Wow.
A combined a pediatric and a medical oncology fellowship. And Houston, it's interesting because I think it's in one of the most diverse places in the U.S. It's one of the world's largest cancer centers in a hospital area, and the entire zip code are just hospitals there. Right? Again, for someone who grew up in hot weather in Chennai, I think Houston surprisingly felt like home.
Yes.
And the hot and humid Houston weather made me feel really at home. And the Texas Medical Center is one of the largest places in the world.
Definitely.
So at MD Anderson Cancer Center, I met with amazing mentors. Dr. Emil Freireich, who in the 60s cured pediatric leukemia.
Wow.
Dr. Emil Freireich, you may not know, he is known as the father of oncology clinical trials. And he's featured in the book by Malcolm Gladwell called David and Goliath.
Oh,
he's the centerpiece of the entire book.
wow.
He was like a grandfather figure to me in oncology. He inspired me to be where I am. And I met with other amazing, inspiring faculty like Russell Kurzrock, Dr. Pete Anderson, who really wanted me to think about not accepting status quo in oncology.
Yes.
Yeah. Looking for the next cutting edge treatment options. I think that's what inspired me for a career in new drug development, cancers. And it's been a phenomenal journey the last 2 decades.
That's amazing. I think of Houston, even though it's a big city, it's Texas. I think like there are cowboys
Yeah.
in the medical field in
Yeah,
Texas.
yeah,
So I
absolutely.
think of Dr. DeBakey, I think of Denton Cooley, doing things to the heart that nobody's ever done before, and that same kind of ethos translates over
Absolutely.
into oncology.
Yeah, Houston is an interesting city. It's a city without pretense. It's scrappy, it's ambitious,
Yes,
and you get all the cuisines in the world,
for sure.
right? I think it's one of the best kept, underrated cities in the US.
Absolutely. Yeah. Vivek, will you please tell our listeners what a phase 1 or phase 2 trial is?
Again, as you know, cancer is tough, cancer is challenging, we need new medicines. So for these new medicines, the first step is drug discovery, right? Scientists in the lab discover new drugs, these new medicines. So they discover hundreds and thousands of these drugs. So these drugs are first tested in the lab in petri dishes. If it works in the cancer cells in the petri dishes, they take it to mouse models. If it works in mouse models, then they take it to large animal models like monkeys.
Oh.
And then if it works in monkeys, if it shows promises,
Yeah.
then they take it to humans. First in human.
First in
human. These are first in human phase 1 studies, right? Again, that's what I do. Again, from discovering hundreds of thousands of drugs, it comes down to, if you think about the funnel, 100 drugs may make it to mouse, 50 drugs may make it to monkeys, 2 or 3 drugs make it to humans.
Wow.
Yeah, there is so much, failure in drug development there. And then once we take it to humans, we have to test. We don't know the dose. We won't know the toxicity in humans.
Okay.
That's what phase 1 trials do.
Phase 1 is safety.
Safety and toxicity.
Toxicity.
But now, in 2026, it's not just safety and toxicity. We want to see responses as well.
Okay.
Yeah, we want to see responses as well because no patient or no physician wants to enroll a patient on a trial without benefit. So phase 1 trials of 2026 are different from phase 1 trials of the 1960s.
Okay.
Because we expect clinical benefit as well. And there is definite therapeutic intent in 2026 phase 1 studies. So
amazing.
Once phase 1 studies are done, then we identify the dose.
Okay.
Once we know the dose, we test it in specific diseases. That's called a phase 2 study.
Okay.
If the drug makes it beyond the phase 2 study, then they test it with standard of care.
Okay.
As
That's
a phase 3
the
study.
phase 3.
That's a phase 3 study. If a drug passes through all these 3 phases, and then the drug, and if the data is positive,
Yes.
if this experimental agent beats standard of care, then the drug is approved. So drug discovery, drug development is a long, drawn, expensive process.
Yes. There's so many bars to clear there.
Many bars to clear. On an average, it takes anywhere from $800 million to $2.6 billion to get a drug approved.
Wow.
It takes a village. It takes more than a village. It takes a city. It takes multiple countries
Yes.
to get drugs approved.
Wow. Now, which drugs have you researched in phase 1 or 2, if any come to mind? Like, which drugs have you researched in phase 1 or 2 that made it all the way to the market?
Yeah, again, in the last 15 years, I've been fortunate enough to develop at least 12 different medications
Yes.
that have made it to FDA approval for 15 different indications.
That is amazing. I mean, I just think that's like Mario going through all the levels and beating Bowser at the end. I mean, that's
12
that's
from 150.
12
12 from the 150 clinical trials,
from
right?
the 150.
So 12
That's
from there.
amazing.
Yeah.
I mean, I guess if it's 12 out of 150, I mean, what is your view of failure? Like, is failure, I mean, failure is probably something that happens in your line of work, but how do you view it? I mean, how do you deal with failure as a scientist and as a person?
I think failure is the normal. I think I would tell...
Failure is the norm.
Yeah, failure is the norm. So because I would tell residents and fellows and any physician is, you need to be prepared to fail. If you are not failing, you need to be prepared to fail.
You need to be prepared to fail.
If you are not failing, you're not attempting, you're not trying.
That's good.
So think about this. I think it was Thomas Alva Edison. I had to fail 1,000 times to get the 1,001st time for an electric bulb to work.
Wow.
So it's not 1,000 times failure. These are 1,000 attempts to make the 1,001st attempt.
Wow.
So again, we got to be prepared for failures. It's not a bed of roses. It's hard. It's brutal. Again, the 12 drugs approved among 150 is in itself a huge, huge success. And I know so many of my colleagues who've done so much of work, much more than me, who haven't had a single drug, seen through. So again, it's a tough specialty. Yeah. It's a tough area, and it takes true grit, teamwork.
Yes.
Going after it to see the light. And again, I can share with you again some of the drugs that I've given it to some of the first patients in the universe.
Yes.
First patients in the universe. Again, we've seen a drug. I can talk about a drug. It's a RET inhibitor. It's called, the drug is called selpercatinib. And let me talk about that drug.
Okay.
I think it's one of my, again, I would say, I think about drugs as babies.
I was just going to bring that.
I know. Again, when I start testing these drugs in patients, I know which baby can graduate. When I start testing drugs, sometimes you would know in one patient, sometimes you would know in two patients, sometimes you would know in three patients.
Wow.
That this drug would make it or not.
Yes.
So this particular drug called selpercatinib, it's a RET inhibitor. So RET alterations are seen in thyroid cancer, lung cancer, and all cancers, like less than 1% of all cancers.
Yes.
And this was a designer drug going after RET gene. And one of the first ever patients, I still remember, came to us. Again, at that time when he presented to our clinic in Houston, he had failed. His cancer, all the drugs had failed his cancer, right? He didn't fail the drugs, but his cancer.
Right.
So had progressed. So he had been through 6 lines of treatment. So when he presented to our clinic, he was cachectic, had 30 bowel movements a day because medullary thyroid cancer has this paraneoplastic syndrome with hypercalcitonin. So he had 30 bowel movements a day, and he was wheelchair bound, debilitated. So we were designing the phase 1 first in human trial at that time, and we didn't have the time to go through paperwork. So what we did was we designed a customized N of 1 clinical trial, because we knew that we had a drug in the lab.
So a phase 1 trial that involved just
one human being. Exactly.
All right.
Right? Again, this human being was interesting because we knew that there was a drug going after that particular gene that he had, the RET gene and the resistance gene that he had. So we started the drug. We didn't know the dose. So I saw him almost every day in clinic. And the pharmacist, we used to come up with a dose based on dynamic guided PKs.
Yeah.
So we started at an extrapolated dose from mouse at 20, then we went to 40, we went to 60, and then over 3 weeks to 4 weeks, we hit a dose of 160 milligram twice daily, based on all the PK, pharmacokinetics and dynamics.
Yeah.
And he started feeling better.
That's amazing.
And his bowel movement stopped. He got up from wheelchair, all the fluid in the belly vanished.
Wow.
And again, after a couple of months, we did scans. It showed amazing shrinkage. At the time, I felt like some astronomer discovering a new planet. And I'm like, oh my gosh, this is amazing. This is a drug. I think this baby will graduate.
Yes.
Yes. And then, of course, we did the phase 1, phase 2, phase 3 studies. And the drug was approved. The drug is currently approved for all patients with RET positive cancers. Again, these are the stories that keep us about going to work in the morning. Exciting drugs. And we are in exciting drugs.
Something that I read about that, what you're involved in, that I'm really curious about is, it's almost like, what was the phrase? Was it system agnostic or cancer agnostic? Well, what does that mean? I mean, it's just like any cancer?
Yeah. Thank you for asking that. So, again, I focus on this area called tumor agnostic drug development. Tumor agnostic or tissue agnostic drug development.
Okay.
So what is tumor agnostic or tissue agnostic drug development? For the broad audience here, so we are used to thinking about cancer like lung cancer, breast cancer, prostate cancer, kidney cancer, or brain cancer.
As separate kind of
separate entities, right? You have breast cancer doctors, lung cancer doctors, A tumor agnostic drug or a doctor is a different way we think about cancers. It is focusing on the target, not the tumor. Because what we see is, the biomarkers that are seen in cancer, the mutations that are seen in cancer, are shared across multiple cancer types.
Okay.
So if it is the RET gene,
Yes.
is a clear tumor agnostic drug. RET fusions occur in lung cancer, pancreatic cancer, melanoma, sarcoma, any cancer that. So these drugs work on RET fusion. Doesn't matter what type of cancer.
Wow.
So it's a different way we thinking about cancer, and we are entering an era of tumor agnostic precision medicine, where the anatomy, is trumped by the biomarker.
Yes.
And these are exciting times to be in oncology.
Tumor agnostic precision medicine. That is such an amazing concept. Wow. And kind of switching gears a little bit, you were listed as an author on over 450 papers. I mean, just as a guy who's like never written one paper, like how do you do 450? Like what is your nightlife like? I kind of imagine somebody who's written 450 papers kind of going home at night and like in front of their laptop, just like typing continuously. I mean, when I go home at night, I'm like doom scrolling on, YouTube or something, or I'm putting my kids to bed or something like that. I'm not writing papers. So I mean, like, how do you do that?
And again, inspiration from my grandpa. He has written more than 120 plus books.
That's crazy.
Right? I have just written.
No ghostwriter. I mean, he just wrote it.
He just wrote it. Yeah, he just wrote it. Yeah. So yeah, I like writing.
Yes.
Again,
you've got a literary background.
Yeah.
I
like writing, and these are again, I have not written a nonfiction or fiction book yet.
Yes.
Right. But these are we do research, and we need to share this research with the world.
Yes.
Positive or negative. I would say positive. I'm known for my positive studies, but the negative studies are also important because we learn what not to do.
What not to do.
Right?
Yes.
Again, that's why it's important for the patients that enroll on clinical trials. Right?
Sure.
For the brave patients who go on these clinical trials.
They are the heroes.
We need to make sure that these are published.
Yes. Where would you say that like we've made the most progress in cancer care over the last few decades? Because I remember when I was growing up, I mean, cancer was it. I mean, it was a death sentence. I mean, and it's still really bad. But I mean, where do you? But it's better now than it was before. So like, where do you feel like we've made the most gains?
I think that's a great question. I think to all the listeners here, cancer is still a tough disease, right? This is the emperor of all maladies.
Yes.
And it's going to take all of us to, get rid of cancer. It's not just one disease, it's hundreds and thousands of diseases. So where we have made the decisive assault on cancer is 20 years ago, they said we cannot sequence a human genome. Then it took $3 billion to sequence the first genome. Right now, we can sequence the genome for a few $1,000s. The other day, I saw a company post that they can sequence a genome for $100. Colleagues in Shanghai, Mumbai, and Singapore have said that they can take it to $1 in the next decade. So the genomic revolution, $1. It's going, not today, but 10 years from now, hopefully sooner than that, right? So if it's $1 for sequencing the human genome, now it takes a few $100s to $1,000 here in the US.
Yes.
And we are able to sequence the genes. So that is the first revolution, that we are able to sequence and molecularly profile cancers. Number two is the drugs that can go after these alterations.
Yes.
So targeted therapy, immunotherapy, and now we have something called the antibody drug conjugates. Targeted therapy are precise guided missiles that can go after these mutations.
Yes.
So take, for instance, CML, chronic myeloid leukemia. This was a fatal disease and a death sentence 25, 20, 30 years ago.
Yes.
And they discovered this, alteration, the rearrangement, BCR-able rearrangement, the fusion.
Right. Yes, yes.
And now, most patients with CML die with CML, not of CML.
Yes.
And
it's turning cancer into that kind of
chronic disease. Chronic
Yes.
disease. They die of natural causes.
Yes.
And they are able to do that with just a pill every day. Most of them can just take a pill every day.
Yes.
And again, these are unprecedented advances. Think about melanoma.
Yes.
The overall survival used to be 8 to 9 months. Now, patients are cured with Nobel Prize-winning immunotherapy.
Absolutely,
Right?
absolutely.
So that's where we have
That's
had a disease of assault on
gains.
cancer.
Well, I listened to one of your podcasts, and one of your authors said it kind of broke down cancer in terms of prevention, screening, and therapy. And certainly the big gains in therapy. But, I don't want to underestimate or short sell screening. Screening is so important, and this is a great time for an ad. If you are a woman between the ages of 40 and 74 and at average risk for breast cancer, you should get a mammogram every year or at least every other year to screen for breast cancer. Schedule yours today at tristarhealth.com/mammo or call 615-695-7230. That's 615-695-7230, or scan the QR code if you are watching this video podcast. Now, Vivek, you have addressed the United Nations, I think twice. Is that right?
Mm-hmm.
Now, something I'm just kind of curious about. Are you in the United Nations General Assembly Hall where Nikita Khrushchev famously banged his shoe on the desk? I mean, this is 1960.
Yeah.
Or are you in the Security Council chamber where they're like deciding, I don't know, like how to stop wars and that kind of stuff? I mean, where are you addressing the United Nations?
And again, it was a unique experience.
Yes.
Right? United Nations, being in the United Nations, being invited to the United Nations was a privilege and honor of a lifetime. And just to be there twice was an extraordinary experience. Again, the Green Room in the United Nations is a surprisingly quiet place. Again, after the
quiet place.
A quiet place, yeah.
Okay.
Yeah. Again, it's like two, go through security just like the airport.
Yes.
Right? Again, of course, the TSA pre and clear don't work there, so you need to go through the security in the airport. Once you're there. You meet with presidents, prime ministers of many countries are just walking as normal people there.
Wow.
Some big countries with huge security.
Yes.
Detail with them, but once you're in the building, you're in the building.
Wow.
And
what have you been asked to share with them?
Again, cancer, right? As we all know, cancer is if you think about the Hercules and the Hydra, it is the Hydra.
Yes.
9-headed Hydra, right? So one of the challenges with cancer is in LMICs, the lower middle income countries, cancer is a huge challenge, and it takes a huge toll on humans. Malaria, HIV, TB combined, right? But many of the LMICs don't have the resources.
Okay.
We have challenges in the US.
Yes.
If you go to rural America, there is not many access to cutting-edge diagnostics, cutting-edge drugs, cutting-edge tests, and clinical trials.
Yes.
And that is exacerbated all across the globe. Like 2/3 or 80% of the world does not have access to this. So I think that was the discussion. Centerpiece of discussion is it's not just drug discovery. It's not just new drugs. How can we think about cancer as a challenge to humanity? I think fighting cancer is the only battle that is worth fighting for.
Yes.
Across the world.
Yeah.
So we need to think globally and act locally. How can we get these diagnostics? How can we get these drugs, these precision medicines to patients everywhere in the world?
Yes.
Right? Not just in some countries, across all countries. Again, that is the discussion. Because, again, that is where you have politicians who are powerful, as you know.
Yes.
Policymakers, health ministries, and all that. I think you can enact change.
So there's a little bit of an element that, I don't want to say everything is political, but politics kind of shapes the way we fight a disease like cancer.
Absolutely, because in many countries, the priorities, right? Cancer is not the top priority in many countries. So again, they bring oncologists to talk about the problem of cancer and what we do in the US, what cutting edge stuff we have in the US, so that those countries, the health ministries there, the prime minister, the president of those countries, realize that they can do that too.
Yes.
Right?
Okay.
They can do cutting edge stuff too. I think it is the last mile that they can help their country.
Yes.
Right. So again, that is education, awareness.
Yeah,
right?
yeah. Well, that's amazing. Now, I believe that you have some. I believe that you have some news to share.
Yes.
I mean, this is kind of bittersweet, but I mean, I'll let you just go.
Yes. This summer, I've accepted to move to California.
Wow.
To Stanford. So at Stanford, I will be a professor of medicine and of pediatrics.
Kind of the second go around to Stanford.
Yes, second go around to Stanford. Wow. Yes, it sort of feels like homecoming.
Yes.
Right. So I'm in the division of oncology, and also leading the early drug development program.
Amazing.
And also the executive medical director for the Stanford Healthcare.
Wow.
For clinical trial network development. Again, it's been amazing time for me in Nashville. It was a privilege to work in Nashville at Sarah Cannon Research Institute. Sarah Cannon and MD Anderson shaped me for where I am, and taking all the knowledge, lessons, and experience from this place to work with cadre of scientists to get them faster. I think. As we didn't talk about this, AI, artificial intelligence, AI is transforming oncology, precision medicine as a whole.
Absolutely.
Again, where, as you know, Silicon Valley, Stanford is one of the top-notch places there.
Yeah.
And I think we can bring medicines faster to humans. Patients cannot wait.
Now, you've been a leader in several different contexts. I mean, something I'm curious about just in terms of leadership is how do you build a culture? How do you do that? I mean, do you take stuff? I mean, what did you take from, for example, what did you take from MD Anderson? What did you take from there and bring over here? And what are you going to bring from here over there? How do you do that?
I think that's a great question. I think you do by example.
By example.
I think, by example, right? You want to make sure everywhere we need to understand why we do what we do. Again, we are all temporary beings in the world. Again, each of us has a role to play in society as a whole. And why we do is for our patients.
Yeah.
So any drug, any treatment, any care, as long as it's patient-centric, think about the patient in the center. I think that should be the central mantra.
Yes.
Getting the right drug to the right patient at the right time, and everything has to be patient-centric. And that's why we do what we do.
Yes, absolutely, absolutely. Well, I'm kind of curious as we close. I'm kind of curious, like, what a great week or a great day looks like for you. I mean, it doesn't have to be an hour-to-hour count, but what elements make for a great week for you?
I think that's a great question. A great week, I would say, good sleep.
Good sleep.
Good sleep.
Right? That was at the top. That was near the top of my list. I was going to ask you how much you sleep.
And again, I'm okay with 6 hours of sleep.
I gotta have 8.
Like deep sleep,
I gotta have 8.
Right?
Okay.
6 to 7 hours of deep sleep.
Okay.
Because again, I've learned the hard way, right?
Yes.
If you don't sleep well, I think that's for all physicians, all residents. We need to make sure that we take care of ourselves.
Yes.
Right. Everything suffers, right? The clinical judgment, reaction time, the patience with people, patience with patients, patience with everything.
Yeah.
Right. So again, good sleep, good breakfast.
Good breakfast,
and then get this day started in the clinic, getting good news to patients.
Good news is always great.
Again, the Emil Freireich used to say that the best or the good doctors are the ones who take care of patients who no one wants to treat. Right. That's when patients come to our phase 1 clinic. They've been told by their physicians that they don't have any options.
Dr. Van Deventer says anybody can take care of the easy ones, but it takes something special to take care of the challenging ones.
I completely agree. Again, that struck me. I think my first year of fellowship, Frederick said that, I think that's been my guiding inspiration.
Yeah.
Right? So again, when we give good news to patients, again, most of our patients, right? These are the brave patients. We just administer the drugs to them. They are brave patients who are volunteering themselves with these new drugs.
Yes.
It may or may not help them, but it's going to help another patient in the future.
Absolutely.
Right? So again, we are thankful for our patients. I think we need to think about this patient centricity. I think that's a good day, right?
Yeah.
And then, of course, going back and hanging out with kids.
The kids.
The kids, right? Yeah. Again, hanging out with
so
kids.
precious.
Yeah, they don't care about.
You cannot get that back.
Yeah.
It's just. It's beautiful.
They don't care about how many publications you have, who you are, what you are, right? They're like, hey, just hang out with me. Just listen to me play the guitar, right?
Well said. Well said. Wow. Well, any closing thoughts? Like anything you want to say to all the doctors listening or watching this podcast or general public?
Yeah.
We've covered a lot of ground, but
again, I would say
you get the last word.
Oh, thank you so much. Thank you so much for having me here. I would say to all physicians in general and all the residents and fellows, right, the next generation people.
Yes.
I think that's where we need to sow the seeds. Remember why you started. The system is tough. As physicians in 2026, the system will grind you down. The paperwork, the insurance denials, the administrative burden, the long hours.
Yeah.
But think about that. Why you, Dr. Phil, me, started this for patients.
Yes.
I think in your training, somewhere in medical school, residency, fellowship, or in practice, there was a patient that probably made you feel that this was the right thing to do. Hold on to that.
Yes.
And never say never. Never stop learning. Medicine is an ever-changing science. And with AI, it's going to become harder and harder. Right?
Yes.
Again, the knowledge is going at an unbelievable pace. So we can use AI to learn, but still we need the human touch.
Yes. We always going to need the human touch. Man,
right?
thank you so much.
Yeah.
Here's a hat. Here's a hat for being our first guest on Doctors Chillin. Doctors Chillin, thank you for your time and all you do to care for and improve human life.
Thank you.
We wish you all the success in the future and hope to talk to you again. Well, that's going to do it for us today at Doctors Chillin. Today was our very first episode of Doctors Chillin. Thanks so much for being here for a little slice of history. Hopefully today will be the first of many Doctors Chillin episodes to keep you informed and entertained on the art and science of medicine and interesting topics in healthcare. At Doctors Chillin, we want to build a community where we can all learn from one another to care for and improve human life and make the world a better place. Medicine is one of the greatest professions and callings, and we need to support one another, celebrate each other, and work towards an even better future. I'm so thrilled and honored to get to host the very first episode of Doctors Chillin, and it would not have happened but for some very important people. Our producer, set designer, audio engineer, videographer, editor, and promoter, Sarah Scandlin. Our resident expert, did you see what I did there? Dr. Cameron Tate, resident expert. Our director, research advisor, and the one who makes it possible for us all to get scholarly and continuing education credit for these episodes, Jordan Rahm. Our executive director and mastermind, Dr. Carl Van Devender, from whom this whole idea for a podcast came along with all our A-list guests. Thanks again to Dr. Subbiah, our illustrious and amazing guest today, and hopefully the first of many more to come. And of course, a special thanks to you, our listeners. We couldn't be us without you. So from all of us here at Doctors Chillin, have a great rest of the day or night. Let's do it again real soon. Until then, be safe and be well.